Elise, any word?
I'm going to call Seth right now. Why don't you get started, and I'll work on it so you won't be held up.
Great, great. Thanks
okay.
so much.
Anytime.
All right. Welcome, everyone. Good afternoon to you. Thank you so much for joining us for this webinar entitled Empower, a community-based approach to improve care for women and newborns affected by perinatal substance use disorder. And as I said, if you need the captions, you can click on the link in the chat box. Okay. So I'm your host, Susan Halpin. I'm the Education and Outreach Coordinator for the New England region of the National Network of Libraries of Medicine. We are located in the University of Massachusetts Medical School in Worcester, Massachusetts. This webinar is being recorded. You will receive a link to the recording and the presentation slides and any other materials in about a week. If you would like, well, I already said, if you would like to view the captions, they're in the chat box. This webinar will last about 40 minutes, 40 to 45 minutes. If you have questions about what you're seeing or hearing, please jot down your questions, and we'll save the last 10 minutes for you to ask. And because there's so many people registered for the webinar, we're going to use the chat box for the questions, but both Linda and I will be manning the chat box, so we'll try and get to as many questions as we can. For those of you who aren't familiar with the National Library of Medicine, I just want to take a minute to tell you who we are and what we do. So the National Library of Medicine is a physical library. It's located on the campus of the National Institute of Health. It's the largest biomedical library in the world. All of the health and medical resources from the NLM, that's it for short, are online, and they're available to everyone. And the NLM is the #1 largest providers of digital content by our government. And the mission of the NLM is to advance the progress of medicine and improve public health by making biomedical information accessible to everyone. And so how we do this is the NLM carries out its mission through a national network that has about 7,000 members, and anyone can become a member. And these network members come from all walks of life: librarians, healthcare providers, public health professionals, educators, students, researchers, healthcare providers, first responders, and even consumers. And last year, the network provided training to about 77,000 people. The National Library of Medicine has some great resources for substance use disorder, and these are online and updated frequently. So these links will be provided to you when, well, many of you have received the resource packet when you registered, but we'll also send you this information when you get the recording link for this webinar. And one other resource, or two other resources I wanted to point out quickly. The first one is LactMed, and this is a useful resource for breastfeeding mothers from NLM, and it's a database. Many of you may find this very useful because it contains information on drugs and other chemicals to which breastfeeding mothers may be exposed. It includes information on the levels of such substances in breast milk and infant blood, and possible adverse effects to the nursing infant. and LACMED is updated monthly. And another resource that the New England region offers to those in New England is a book club kit. If you provide programming for your organization, you may be interested in these graphic medicine book club kits. And graphic medicine books are novels written in comic book format, and the combination of visual pictures and written word is a very effective medium for novels that deal with topics that may be difficult to discuss. So some of the topics that we have novels for are substance use disorder, aging, cancer, mental health. These book club kits contain 6 graphic novels, discussion questions, and then NLM resources related to the topic discussed in the novel. Anyone in New England can borrow this kit free of charge, and it will be shipped to you. And the contact person is listed on the slide. It's Sarah Levin-Lediter, and she is the NER's Education and Outreach Coordinator in charge of our kits. All right, now I'd like to introduce our webinar presenter. Linda Jablonski is the Assistant Nurse Manager of the Birthplace at Bay State Medical Center, and she's also the co-chair of the Franklin County Perinatal Support Coalition. So I'm going to turn the presentation over to Linda right now.
Hello, everyone. I am actually the Assistant Nurse Manager at the Birthplace at Bay State Franklin Medical Center. We are north of Bay State Medical Center, part of the Bay State Health System. I want to thank you for joining the webinar today and for your interest in learning more about perinatal substance use, which is a significant public health issue in our country today. So I have no actual or potential conflict of interest in relation to this program presentation. And my hope is that at the end of this webinar today, the audience will have a better understanding of the unique implications that opioid use has on pregnant women and their newborns, and how providers and communities can work together to build a real team of support for this very vulnerable population. We will begin with an overview of perinatal opioid use, and then we're going to discuss strategies that healthcare providers and communities can utilize to identify and address barriers to care that these women face. And finally, we're going to explore the need for and the benefits of addressing this public health issue utilizing a comprehensive, collaborative, community-based approach. So I'd like to begin by just reviewing some terminology that I'll be using throughout the presentation. There is much discussion today in the literature about the importance of the language that we use when we are discussing addiction. Our language is very important because it can be received in a way that inflicts stigma and judgment if we're not careful with our words. We must all keep in mind that addiction is a disease, and a person with an addiction deserves the same level of respect and access to care as a person with any medical condition. If anyone's interested in more information about the use of language and addiction, the NLM webinar that was broadcast in August called Words Matter is an excellent resource. So let's look at our terms here. The first is substance use disorder. I actually like to avoid the term disorder, especially when I'm speaking to patients. It's still common in medical terminology today, but there are alternatives. Another is called opioid use disorder or opioid misuse. I prefer to use the term perinatal substance exposure, especially when I'm talking with women and their families. I may also use the term substance use. The second term that you'll hear me using is SEN, which stands for substance exposed newborn. This is a newborn that, while in utero, was exposed to any substance. Another term similar to this might be opioid exposed newborn, or OEN. Next, moving on, is neonatal abstinence syndrome, NAS, and this refers to a withdrawal syndrome that some newborns experience who are exposed to opioids in utero. So to clarify, SEN, substance exposed newborns, are all newborns with exposure, And then NAS is a subset of those newborns who are exposed to opioids and actually show signs of withdrawal after they are born. And finally, medication-assisted treatment, or MAT. This is the use of medications in combination with counseling and behavioral therapies to provide treatment of substance use. The medication works to normalize brain chemistry. It blocks the effects of opioids. It relieves symptoms like cravings, and it does so without the negative effects of the opioids, of the drug of abuse. So next, how prevalent is perinatal substance use? It's always difficult to get timely statistics about the opioid crisis, especially for perinatal substance use. But what's clear is that the rate has been increasing dramatically over the last few years. This graph shows the rate increase from 2011 to 2013 in births per 1,000 babies having neonatal abstinence syndrome. The blue line at the bottom of this slide shows that the rate of NAS in 2013 in the U.S. was 5.9 per 1,000 deliveries. And if you back that up, the slide doesn't show that, but in 2000, the U.S. rate was actually only 1.19. So it has grown significantly. The red line at the top reveals that here in Massachusetts, the rate is almost 3 times that as seen at the state level, at the national level. So what exactly are the risks of perinatal substance use? Research shows that women are actually at highest risk for developing substance use during their reproductive years, so between the ages of 18 and 44. The most commonly used substance in pregnancy is actually nicotine, then followed by alcohol, marijuana, and cocaine. Here in Franklin County, heroin is actually the drug of choice. It's inexpensive and it's easy to get. Women using illicit drugs have a higher rate of miscarriage, preterm birth, and placental abruption. They are also less likely to participate in prenatal care and attend their regular visits. Risks to the baby include growth restriction, low birth weight, and NAS. And babies also may be at a higher risk for long-term side effects. We'll talk about that when we get a little further along in the webinar. So how do we treat perinatal substance use? The American College of Obstetricians and Gynecologists recommends medication-assisted treatment in combination with counseling and behavioral therapy and access to a wide range of support services. This slide shows the 2 approved medications for women during pregnancy. The top, the pill form, is buprenorphine, or it's called, the brand name is Subutex here, and also methadone. So MAT is typically recommended instead of withdrawal or abstinence. Many women who are actively using opioids may want to stop on their own. This happens a lot with the moms in our program. They find out they're pregnant, they're on a medication-assisted treatment, and they want to stop because they are concerned about the effects that it may have on the baby. However, that is not recommended because there are some advantages to being on medication-assisted treatment. As you can see, the bullets, it stabilizes. Having that constant level in the bloodstream stabilizes the blood levels. It reduces harm to the fetus, reduces the illicit drug use that the mom may have because her cravings are being taken care of, her other symptoms of addiction. It also reduces the risky use. A risky use would also increase infectious disease. So having that stable treatment of medication is best for moms. It also has been shown through research to prevent relapse. And of course, if we're more stable in our treatment, the moms are going to adhere to their prenatal care schedules. And also because that baby is more stable in the uterine environment, they're going to have improved outcomes. And again, it's always done best in combination with behavioral therapy. We'll talk a little bit about neonatal abstinence syndrome before we go on. Not all babies who are exposed, not all SEN babies, substance-exposed newborns, develop NAS. And we don't know why this is. There's been a lot of research done. But what the statistics show is that about 50 to 90% of those SEN babies will go on to develop NAS. Because opioids cross the placenta, and while the baby's in the uterus, the baby can become physiologically dependent on whatever substance it's been exposed to. After birth, the baby may begin to show signs of withdrawal, which the symptoms can develop immediately or up to 5 days later. Symptoms include hypersensitivity, hyperirritability, tremors, vomiting, respiratory difficulty, trouble sleeping and feeding, as well as many other symptoms. The range and severity of these symptoms depends on a variety of factors, including the type of opioid that the baby was exposed to, and also whether they were exposed to multiple substances. If a mom is on medication-assisted treatment or if she's actively using and she's using multiple substances, maybe she's smoking marijuana as well as cigarette smokes, that is going to increase the chance that the baby will show signs of withdrawal. Babies will need to stay in the hospital to be observed for signs of withdrawal for an average of 3 to 5 days. And treatment protocols really vary across the country between hospitals, but generally what's done to treat neonatal abstinence syndrome is their babies are given a small dose of an opioid medication, such as neonatal morphine or even methadone, and that stabilizes the baby's symptoms, and then the baby is slowly weaned off until all symptoms subside. And treatment usually takes anywhere from 1 to 3 weeks, and neonatal abstinence syndrome is treatable. The last bullet on this slide is something I'm very passionate about communicating, and pretty much I want everyone to understand that babies are not born addicted. Neonatal abstinence syndrome is not addiction. The term addiction is inaccurate and it's stigmatizing. Addiction is a chronic disease that has biological, psychological, and social manifestations such as cravings and drug-seeking behavior, relapse, and recovery. Babies may have a physiologic dependence on the substance they are exposed to, but they are not born addicted. Mothers with substance use who have no other medical contraindications should be encouraged to breastfeed, unless the risk of substance use outweighs the benefits of the breastfeeding. So breastfeeding on medication-assisted treatment is actually an advantage to the baby because the baby is used to getting that in their bloodstream, having the medication in their bloodstream, and so when the cord is cut and the baby starts to breastfeed, a little bit of it does get into the breast milk, and it can actually help decrease the chance of the baby going into withdrawal and help any symptoms that it may be having. So medical contraindications to breastfeeding include HIV infection and some prescription medications that are labeled as harmful for breastfeeding, as well as moms who are still actively using substances and those who express no real desire to stop using. They're not yet in recovery and they're actively using, that we would not recommend breastfeeding in that case. And then non-pharmacologic treatment for neonatal abstinence syndrome is the standard of care. Forming a real healthy maternal-infant attachment from the moment of birth is really critical for both mom and baby, and so keeping babies together, keeping them skin to skin, helps regulate their breathing and their vital signs. It calms their nervous system. And other interventions can be done, such as decreasing the stimulation with the baby, dimming the lights in the room, keeping them nice and warm and snuggled and swaddled up. The photo at the top right is one of our cuddlers snuggling a baby being treated for NAS. As part of our program, one of the first things we did was develop a cuddler program, and we've trained over 40 volunteers in our community who come in to help support these moms and babies by giving them lots of extra TLC. The literature has mixed results in terms of the long-term impact that substance exposure may have on these babies. One of the challenges to this research is the effect of other compounding variables, such as psychosocial factors in the family and social determinants of health. So it's hard to sort those out from the research results. Some research has demonstrated links to learning and attention deficit disorders, developmental delays, behavioral and emotional developmental issues. And studies have also shown that these children may be at higher risk themselves for developing substance use in the future. So I'll talk a little bit about our community to give you some context. Greenfield is a rural community. We're one of the 26 towns in Franklin County. We are in western Massachusetts. We have a population of 71,000 people. And here at the birthplace, we deliver just about 450 babies a year. We're a small rural hospital. The women we serve we have very little diversity in our communion, about 91% white, 5% Hispanic. 50% of our population qualifies for mass health, so we have many people at the poverty level. And then we have excellent community involvement here with the opioid. We have a very active opioid task force here that helps us address these issues. So I have the opportunity to lead two different groups that are actively involved in addressing the opioid crisis here. The photo on the left is a picture of our clinical nurse practice team, and you can see our mission statement right below, which is to systematically evaluate and implement measures to improve the quality, safety, and effectiveness of nursing practice for women and newborns. And in 2012, this team recognized that we had an increasing population of women here in our community coming in to have their babies with perinatal substance exposure. And the team really wanted to improve the care we give to these moms. Women were coming to the hospital to deliver, and they were unaware of all the things I had just talked to you about. They didn't know about the protocols for extended length of stay. They didn't know that the different signs and symptoms, or even that their baby may experience NAS. And they also were unaware that we, as a hospital, have a mandate to report any substance-exposed newborn to the Department of Children and Families. So the nurses felt a sense of frustration and conflicting feelings also about the challenge of caring for this population, and we're very motivated to understand the unique needs and how we could best care for this population. And I also have the privilege of being the co-chair of the Franklin County Perinatal Support Coalition, and our mission is to create a comprehensive safety net for all mothers during the perinatal period in order to support optimum perinatal emotional health. So during the first 4 years, we were established in 2009, and the first part of our work as a coalition was to create a comprehensive screening and referral program for women with postpartum emotional complications. Simultaneous to the practice team's desire to improve care, the coalition began to discuss among ourselves that the impact the opioid crisis was beginning to have in our community. And we were really recognizing an intersection with those moms we were already working with their perinatal emotional complications such as anxiety and depression, postpartum depression, and then this new population of moms in our community with perinatal substance use. So it made perfect sense for these two groups to come together in order to widen our safety net and address the needs of women with perinatal substance use as well. So this is just a quick diagram of the model that we use. When our coalition started, we partnered with Mother Women, a local grassroots women's advocacy agency that was working to develop a community-based support model to address perinatal emotional complications. And this diagram represents the model we used. The first step was to assess community readiness for change on the left there. And then there's a sequence of events that follow, including public education, professional training, identifying resources, developing resource and referral and triage protocols. And finally, the final step is to actually implement a screening protocol. And all with the result of improving outcomes for women at risk for perinatal emotional complications. So again, the first 4 years of our coalition's work was to create a comprehensive screening and referral program for women with postpartum depression. And since we already had this in the community, it laid a perfect foundation for us to begin to address the issue of substance use in our community. Again, another graph just to bring you a little bit closer to Franklin County and where we stand. This graph was published by the Health Policy Commission, and it reveals that our nurses and our community partners were not imagining the problem. There are 50 birthing hospitals in the state of Massachusetts, and I've highlighted our hospital there in yellow, Bay State Franklin. We have the 8th highest rate of NAS in the state of Massachusetts. Our rate varies from time to time. It alters between 7 to 8% of our total births. Babies have substance-exposed newborns. And then of those substance-exposed newborns, about 40% of those here at Bay State Franklin develop and need to be treated for neonatal abstinence syndrome. Another picture that kind of describes, so I know when I start to talk to people about perinatal substance use, they often have questions about, so what does that look like? Just to give you an idea of what we're seeing in Franklin County, this was a snapshot that I took in 2017 of where we were at for the year in terms of what the substance exposures look like. So if you start with tobacco on the bottom left corner there, 23 out of the 24 women I had worked with at this point in 2017 smoked cigarettes. We have 3 times the national rate here in Franklin County of cigarette smoking. The state rate is 5.5%, and our rate here is 15%. If you go up to the next level, the good news here is that 23 out of 23 of the moms in our program to that point in time were on medication-assisted treatment. And then if you go above that, the bad point was that at some point in pregnancy, more than half of the moms here in Franklin County either used cocaine or heroin, so had actual illicit drug use during their pregnancies. Benzodiazepine, which is a medication for anxiety, it has significant impact on NAS as well. 5 out of 24 moms had that exposure. And then some moms have chronic pain issues, and they need to be prescribed opioids to manage their pain. And we had 1 out of 24 in that situation. And then we also have people who abuse prescription opioids. They might buy them off the street, or they may get more than one opioid, and not just for pain management, but as an addiction. And finally, Massachusetts just legalized marijuana, and more than half the newborns, as you can see to this point last year, were exposed to marijuana during the pregnancy. Many women are under the impression that since it's legal, it's not harmful. They use it for nausea in early pregnancy or for anxiety. When I meet with moms, I explain that although it's legal, it does have harmful effects on the baby, and we recommend that they not continue the use. So this is, in 2016, SAMHSA published this report supporting the use of a collaborative approach to address the issue of perinatal substance use as best practice. They explain that any response to the many barriers facing the families of pregnant women with opioid use must be grounded in solutions within the community that reflect best practices. So we had already been working on our program when this was published, but it's a great resource. I have it listed on my resource list, and it was definitely a great confirmation to us that we were approaching the issue in the right way. So our approach, substance use disorder, is complex. It is multifaceted. And so the most effective response must be a comprehensive multi-system approach that can only be done at the community level. And foundational to the community-based perinatal support model is the need to begin identifying and addressing barriers to care at all levels. You can just jump in and start doing screening and referral programs, but really it's worth it to take the time and stop and consider where your community is at each level. So our first step as a nurse practice team was to visit the local methadone clinic. I have been in nursing here at this hospital for over 30 years, and I was very unaware. I did not know where the methadone clinic even was. So it was a very valuable time together. We took a trip there. We met with the nurse. We met with the clinical director. We walked through the experience from the waiting room to we saw where the medication was administered. We talked to the counselors, and it was very, very important for us to do that in order to consider the experience of our patients. In order to understand our provider barriers, we met with the midwives and the doctors and the nurses and the MAs at our local prenatal office and discussed the challenges that they faced. What would it look like for them to add another screening tool to their daily workload? How comfortable they were screening? And then finally, our first step as a coalition was to host a community conversation about perinatal substance use. We invited everyone in town that offered services to women and invited some experts from DPH to describe the scope of the problem in the state and also present best practices to us. We also invited a mother with lived experience to tell us her story of having a baby in Franklin County. And honestly, some of what she shared back then was hard for us to listen to because she described the stigma she felt, how difficult it was for her to get the care she needed, and the trauma she experienced when her baby was later taken into DCF custody. So let's talk about those individual barriers that we have learned about in our journey. The first, the addiction itself can be a barrier. If a woman is actively using, it can consume her behavior and prevent them from getting the help they need. If she's spending time and resources deciding how to get the next dose of heroin, that can be all-consuming for her. If you're actively using, you don't want to go to the healthcare provider, and you certainly don't want to give a urine sample and have your addiction discovered. My office is just a parking lot away from the OB clinic in town, and quite often it's hard just to get them from there to here, just because they have so much fear and they're just the unknown. They don't necessarily want to face it, and so especially if they're using, it can be a huge barrier for them. The other issue that's quite significant is coexisting mental health diagnoses. 2 out of every 3 women with substance use have coexisting mental health diagnoses, the most common being anxiety and depression. Many women I meet with have depression and anxiety, long histories of it. I recently spoke to a mom who was convinced that it was her postpartum depression that actually made her relapse. She had been in recovery for many years, had another baby, and had significant postpartum depression which after some therapy, she realized that's what actually triggered her relapse. I met with a woman last month who was struggling with ADHD. She had discontinued her medications because, like so many other women, she was afraid that that medication may cause neonatal abstinence syndrome for her baby. But because she had discontinued it, she was becoming symptomatic. And she described the ADHD so well to me. She said this: "I feel like there are 1,000 jumping beans in my head all day long, and I just can't think straight." She also said, "I feel like if I drop a penny on the floor, it will explode." So imagine the barrier of this woman would have in getting the care that she needs, which includes scheduling and keeping all of her appointments, trying to work with insurance to get approval of care, trying to find a counselor, trying to figure out paperwork for food stamps and WIC. All of these medical diagnoses can be huge barriers. One of the biggest barriers is fear. Fear of condemnation, fear of facing their addiction, fear of judgment. The biggest fear that I hear, though, is of the Department of Children and Families. Each state has different reporting laws, and here in Massachusetts, we are mandated to report. So women carry that fear with them that they may actually lose custody of their children to DCF. They may be afraid to disclose their use to a provider who may judge them or report them. I recently spoke to an online support group of women on MAT, and many share stories of being mistreated by healthcare providers, and they're afraid to speak up for themselves because of the threat that the provider may report them. And stigma is also huge for these moms, and we've talked a little bit about that. Imagine yourself in the waiting room at the MAT clinic, and you're publicly identified as a person with addiction right away because you're there waiting your turn. And then now imagine that you're pregnant. Media portrays images of babies born addicted and sensationalized images. And if a baby is a victim, then that means the mother is the perpetrator. So these women carry that burden of feeling judged and stigmatized. And guilt and shame is another huge thing for these moms. They often carry that with them. They don't get up in the morning and decide to become an addict. I get lots of questions about the long-term effects of using an MAT. Moms are concerned about their babies. Part of what I do with moms during my business is explain the symptoms. It's often difficult for moms to hear because they know how they feel when they go into withdrawal. So I'm always really careful to explain the things that they can do to decrease the chance of withdrawal and the important role that they will have. We'll talk about that more in a bit. So a family history of drug use, substance use also increases the chance of moms going in. Is also an individual barrier, as well as PTSD. I meet with 30 moms a year, and I can tell you that I can count on one hand the times that the moms will talk to me, tell me their stories, and they just say, "Oh, I just made a stupid mistake when I was a teenager and I started to use." Most of these moms relay really passionate stories about trauma that they had as a child and things that led them on the path that they're on. And finally, economic security is a huge barrier, especially here in a rural community when you live miles away from resources. I have several women I'm working with right now who would love to take advantage of services in town, but they live so far out of town. The very first woman I met with for our program was homeless, couch surfing, fleeing from domestic violence, and had no transportation and wanted to resume treatment at the methadone clinic. So how could she do that without significant support to overcome those barriers? So the good news, I just said a bunch of bad news, but the good news is that pregnancy is a huge motivator. It's a wonderful opportunity because moms are able to see a healthcare provider at regular intervals during their pregnancy. And this slide just shows a study that revealed that both motivation to seek treatment and or intensify treatment is increased as each trimester comes. So some women experience as much as an 80% decrease in use by their third trimester. So let's talk a little bit more about provider barriers to care. Our providers expressed the need right off that they wanted more training for substance use as well as perinatal substance use. One of the first issues that presented a challenge was providing adequate pain control in labor and postoperatively for our C-section patients. People with substance use can require 2 to 3 times the amount of pain medication in order to maintain adequate pain control. The providers said they needed a screening tool. Providers were certainly asking questions for substance use, the history of substance use, but we didn't have a validated screening tool. If a patient revealed that they had a problem, there was no protocol for response. So it's one thing for a provider to ask a woman, are you using? And then it's another to know exactly what to do if she says yes. So they were in need of protocols. Also workflow, providers have 20 minutes with a prenatal patient at each visit, and there's a whole list of other things they need to accomplish. So how could they add yet another thing to their workload and have time should the patient screen positive? Our electronic medical record did not have a screening tool, and at this current time, the state of Massachusetts does not reimburse providers for their screening, for substance use screening. And then in our community, what were the barriers to care within our system? So we recognized early in our journey that we had many organizations doing really wonderful things, but everyone was working within their silos. Lots of good work going on, but no one was sharing their programs. We're too busy doing our own work. We have several agencies that offer the same services, so there was a little concern at the beginning that we might have some competition when we began a referral process. That didn't turn out to be the issue, but that was one of our original concerns. We had no system for referring on an interagency basis. And interagency, the next three on the slide, collaboration, coordination, and communication, really go hand in hand. It's all very difficult if you don't know how to refer, if you don't have a contact within another agency who you can connect with and discuss the woman's situation and discover whether or not they might benefit from their services. And another big barrier we realized that we had was release of information. We needed to develop a system where we could have women sign a release form so that we could talk about the care between the different agencies. So this is a slide that displays all the logos of our coalition partners. We have 26 different organizations that need to communicate, collaborate, and coordinate care for the women in our community. So now imagine that you're a woman with perinatal substance use, perhaps like the woman in our program who was homeless, fleeing domestic violence, had PTSD and depression, and wanted to get to the methadone clinic. How might she access her care? Where should she start? Or perhaps you're a mom with ADHD. It's hard for you to focus and you feel you're on the edge every moment. How will you approach the motivation, the mountain of need ahead of you? How can we as a community find these women in our midst and support them? How can we offer warm handoffs to get from one place to the next so they can have comprehensive care? It kind of looks like a maze to you, and I can imagine how it feels for these moms. So this was our solution. We developed EMPOWER, which stands for Engaging Mothers for Positive Outcomes with Early Referrals. The first thing that we did was we decided on a screening tool. This is, you're not probably able to read it real well, but it is what's called the 5 Ps screening tool. We did some research. It's one of the tools recommended by ACOG. The 5 Ps stand for parent use, peers use, partners use, past use, and present use. We also decided to add questions about intimate partner violence. And remember, we'd already been screening for postpartum depression using the Edinburgh screening tool. The next thing that we did was we developed a provider a screening protocol. So although our first step was to decide on the tool before we could implement that, we needed to create this protocol because this is the best tool we could give our providers so that they knew exactly how to respond. If a woman finally gets the courage to say, yes, I have a problem, I'm using heroin, then the provider needs to know exactly what to do and how to respond. So this tool equips the provider to know exactly what to do. We invited the Institute for Health and Recovery to come out and develop this tool with us, as well as give us some expert training. If you look across the top column, it lists the question. So the question from the tool, how the provider should respond, gives them ideas about what to say, what sort of educational materials they might share, and finally local resources, including phone numbers to call. This slide just represents some of the training that we did. We have a great local resource in our town that actually is on our resource guide as well. One of our local physicians, Dr. Ruth Cote, does a wonderful webinar on the physiology of addiction and the developing brain. So many of our providers attended that, as well as we did expert training. Asking the question is one thing, but expert training teaches providers more about how to ask the questions, how to do a brief intervention. It involves motivational interviewing as well as techniques for referring to treatment. And then I already mentioned our community conversation. That's the first thing we did. After that, we looked at the barriers we had addressed and decided to expand the members around our table. So we invited the MAT providers to join, residential treatment centers, recovery centers, DCF, and women with lived experience. We meet on a monthly basis, and we hold community highlights where every organization is featured and they can explain the services that they offer. One of the tools that's the most effective that we do is we will come up with hypothetical case studies where we present a situation, and then each organization talks about how they might be able, what they might be able to offer to help, different programs and services. These scenarios are very informative and build camaraderie. I'm always very impressed by the problems we can solve when we all get around the table together. And then building relationships. So this photo is from one of our anniversary celebrations. People get to see each other every month and build relationships, which gives us the ability to network. And I can't tell you how many times I witnessed a moment between two providers who have been referring to one another for years, having phone conversations, but have never actually met. So again, that face-to-face relationship building is a huge way to overcome system barriers. We had a resource and referral guide for post-perinatal emotional complications, and when we expanded, we created the guide on the left, which is a combination of resources for women with perinatal emotional complications as well as perinatal substance use. We also started a recovery coach program in town, which was at that time called Moms Together, and we trained 5 women with lived experience to come beside these moms and offer recovery support and help them maneuver that complex healthcare system we just looked at. And recovery coaches can offer emotional support, provide transportation, and attend appointments, and advocate for these moms as needed. So this is what it looks like, the experience for women now in Franklin County. Remember, we started with no screening at all, except for postpartum depression, and women are now screened by a nurse at their very first office visit. They're screened again at 28 weeks and then at their 4-week postpartum visit. When I explain this process, I'm often asked, why are you screening so often? Well, first of all, it's the ACOG recommendation to screen 3 times. And by asking the question several times, we're really normalizing the screening process and having a discussion about substance use. And we're also planting a seed. So many women are not going to tell the truth. They're not going to disclose their use. However, if this is coming up in their mind at one point when they are ready to get help, they are hopefully going to remember that this is a place where they can come to get the help that they need. So when a woman gives a positive screen for any a positive response to any one of the screening questions, they're then referred to me. You see an arrow at the bottom where it says pregnancy plan. For a pregnancy plan visit, at this first visit, I listen to their story and explain the whole Empower program and offer them the resources we have to choose from. Ideally, the screening and referral happens in the first trimester, so then we have plenty of time to connect to resources. And one of the first things I do, based on their story and their need, is refer them to a recovery coach, if that's appropriate, so that they can have the support they need right from the start. After that, they contact me at any time for questions or further support during the second trimester, and then we schedule a visit at 36 weeks to see how they're doing, discuss their birth plan, and teach them about NAS and what to expect from their hospital stay. So I'd like to share a little bit more about those pregnancy plan visits just to give you an idea of what the moms experience. I have learned so much from these women as I meet with them and they share their stories with me. I do a few things right away to help address the issue of fear and stigma, because I remember I already told you some of them have trouble just even coming in for these appointments. So I tell them about the program and why we developed it. I also let them know that they're not alone. And then I meet with 30 women a year who are all at all phases of their journey, from actively using to having years in recovery. I've also learned over time to ask early in the visit if they have any questions for me, because so often they have 2 big questions on their mind. And they are, is my baby going to experience going to withdrawal, and tell me what I need to know about the Department of Children and Families. So during these visits, I listen to their stories. I offer lots of educational handouts for whatever it is that their history involves to help them out. If they're using marijuana, I talk about that and give them some printed information. And I'm also always careful to share it in a way that is factual and non-judgmental, things for them to consider about their health. And I also will refer them to different agencies in town. And again, I explain the programs and services they offer, and at the same time reinforce the fact that I'm not dictating decisions, I'm merely reviewing options that they have. And then these moms have so much to anticipate as they consider getting ready for their babies. At the last visit, at 36 weeks, I focus a lot on what they can do for their babies. There's so many things they can't control, but there are some things they can control. So I talk a lot about the fact that moms are the best medicine for their babies. And I enjoy telling them that by rooming in and providing skin-to-skin contact and breastfeeding, they can actually decrease the chance that their baby will go into withdrawal. I teach them that their babies already know their voice and that they will soon become experts in caring for them. This is a pregnancy plan that we developed. As we built this plan, it's the most critical tools that we use to overcome barriers to care. Early in our program, we realized that women were having to tell their story over and over again, and we wanted to have a place where they could write their story in their own words. We also needed a way to map out those different resources that we have in our community. So there's different categories. What we did is we came together as a team and said, what's the best possible plan that we could offer for our patients? And we came up with some specific areas that we wanted to make sure that these moms had. We wanted to make sure they were able to build a team of family and friends that were going to be supportive of them. There's another page here that shows, and again, the moms completely fill this out. This is absolutely optional. We want to make sure that they have healthcare providers before they have their babies. It's all set up. If they're on MAT, we want to make sure that they're enrolled in that program. And then we really want to address any physical needs they have or economic insecurity. One of the best parts of the plan is that it not only gives them a power to tell their story, but I also always emphasize that the main purpose of the plan is about them building their team so that they can be prepared. But the other thing that I love to tell moms is that the Department of Children and Families is on our team, and that they were at the table and helped us develop this plan. Many women fear DCF because they don't know what DCF wants from them. And so I get to hand them this plan, show them that it's the plan that we have as a community developed, and they get to choose what they want. The best part of the plan for them is that with their permission, they then sign the plan, and then after delivery, when the social worker comes to talk to them about the report to DCF, the mom signs the plan off, it's completed, and then the social worker faxes the plan to DCF with the mom's permission, and it's really the mom empowered to tell her story in her way, and it's also a benefit for DCF because they have a dump on all the information they need in terms of starting their review. It's one of the best best tools we have to overcome those individual barriers. So after the program had been running for a year, we were curious about whether or not the program was having an impact, and we decided to do a pilot study. This was another great example of collaboration within our coalition. We had one of the members of our coalition is a midwife here at the hospital and also a faculty at the University of Massachusetts, and we had a student nurse here that was working who helped us as a research assistant, and we're now in the process of writing the analysis into a manuscript and have consulted Dr. Peter Friedman, the Director of Research for Bay State Health, so we've got a great collaboration going with this. We decided to do a retrospective chart review with a quasi-experimental design, and our inclusion criteria were women aged 18 or older with substance use and pregnancy who received care at BFMC. We looked at 38 medical records, and we had 19 cases where women who participated in our Empower program, and the second were randomly selected historical controls before the program began. And then we looked at the following outcomes. We wanted to look at initiation of breastfeeding and how long did the moms continue. Did they go on to initiate contraception? What was their experience with prenatal and postpartum depression? How many referrals were we making? And then were there any neonatal outcomes that were positive? So this is just a quick summary. Our focus was on clinical significance for our patients and practice implications. This first slide reveals that more women initiated breastfeeding and were still breastfeeding at discharge when they participated in the Empower program. And this group also had a higher rate of full continuation at discharge of breastfeeding. We were encouraged by that. It's just a list of the prenatal referrals, and you can see the most significant here were the increase in the prenatal referrals as well as recovery coaches. And then for newborn outcomes, we saw an increase in probably the most significant here, just to do quickly, is the gestational, the weight at birth went from 29.63 grams in the not Empower group to 33.67 at those moms who participated in the Empower program. So the opportunities that we still have here, we've accomplished a lot, but there's always more that we can do. We really want to extend the postpartum support. Unfortunately, the structure of our program ends at this point, rather other than the recovery coaches who carry on with them, but we'd love to get more involved in early intervention referrals with these moms. Ideally, we'd love to have a case manager or social worker that's positioned in the office to really do a lot of what I do here as a registered nurse and get them connected to the community. We would love to be able to have individual care collaboration, have release of information signed so that we can, at our monthly meetings, talk about these cases and really collaborate in a live sort of fashion. We've developed support groups and doula programs. We'd love to create a prenatal classes for this group of moms, as well as long-term follow-up. And our goal this year in 2018 is to look at our full spectrum and say, from first visit to 1 year postpartum, what is every interaction these moms have in our community, and to make sure that everyone's around the table to talk about how we can provide best care. The keys to success for our program have really been to focus on patient experience, to have someone with lived experience right at the table because they add so much to our group. And our community-based model has been foundational to our success. And to keep it grassroots, to have a framework, but also within each organization be able to make it flexible. And then leadership is super important. You need the right people around the table that have positions of influence and that are passionate and invested in the work. And then I think, too, the final key is just really starting first by carefully addressing the barriers that you have in your community. And in our closing slide, I've been a nurse for 32 years, and this is honestly the most rewarding work that I have done. It's such a privilege to partner with our healthcare professionals and our community members who are all so highly invested to provide the best care. I have learned so much from the women that I work with. I'm just going to close with a story about this mom here. Her name is Sandy, and she had many obstacles to overcome with her pregnancy. I met with her when she was just 7 weeks pregnant, and she worked very diligently through her pregnancy. Her son did develop neonatal abstinence. She had an extended length of stay with us. And a couple months after she had the baby, she stopped by my office for a quick visit. And as she was talking to me, I was quite distracted because her baby was cooing and smiling at her. And, we worked so hard to really create an environment where these moms and babies can bond, because that maternal-infant attachment is critical for the physical and psychological health of both mother and baby. And at that moment that I was distracted by the baby, I realized that this is the kind of moment that we all strive for, that we had been successful with this mother and baby. We're not with all moms and babies, and we still have a lot of work to do, but it felt good that the safety net in our community had been extended. So Sandy has also recently made a video describing the barriers she faced, and that's also a resource on the list that's included. So that is the end of the content. I'm sorry, it looks like we have just 7 minutes left for questions.
Oh, Linda, thank you so much. This was such an informative presentation. Please put your questions in the chat box. I'm just going to put the course evaluation link up here. Let me take back the ball. So does anybody have any questions?
I do see one question here, Susan. It says, how and where can we get the forms and data that you discussed? So I did not include, that's a good question. So the data, I do have references on the slides, and there's certainly more where that came from. But in terms of the forms that we use, I'm perfectly happy to post our screening form. It is unique. Again, it is the 5 keys, but we added intimate partner violence as well as the Edinburgh postpartum depression score. So it's quite comprehensive, but we're happy to share that as well as our protocols. If screening is something that you're seriously thinking about doing, you really need the even more important work is developing a protocol so that your providers have that tool to not only implement the screening but follow through.
Yeah, I'm not seeing questions here. So Linda, are there others?
Other resources or?
No, other questions. I did not.
I don't see, I don't see any. I do see questions, just can we be provided a copy of these slides?
Yes, those slides, well, actually, I sent them out to everybody who registered already, and you will get them again with the recording link. And here's the, if we really value your feedback, so this is the course evaluation link, and if you're getting MLA credit, you'll need to fill out an evaluation, and the evaluation code is on the slide. It's subuse 2. And while we're, hey, does everybody see the, great. So while we're waiting for other questions, I just wanted to bring your attention to another webinar that's coming up in about a month, and this is called Just Talk About It, and it's about using mental health education to prevent and treat substance use disorder. We have a fantastic speaker. I've heard him twice now from the Minding Your Mind organization, and he's going to share his personal experience just as Linda did, also giving some helpful dialogue to engage with students, friends, family who address, to address signs of this difficulty. So you can, start talking with them and hopefully provide some help.
Susan, I did just see a question. Unfortunately, it flashed on and off the screen, but the question was, can someone be on buprenorphine and methadone at the same time? It seemed like there were 2 parts to that question, but that was the first part. And the answer to that is no. They work differently, and there are advantages to one or the other, but no, you're not on them at the same time.
All right. And I tried to post that person's question. He asked, or do the 12 women receiving methadone and 11 buprenorphine mean that 23 of the 24 mothers were treated with MAT?
Yes, it does. It means 23 out of 24 of them were treated with MAT. So in this community, methadone is it's federally regulated, and it's pretty much mainly distributed at a clinic. Buprenorphine can be prescribed by anyone who is certified. In fact, that's one of the barriers that we overcame here, is that all of our obstetricians are now certified in prescribing buprenorphine. But there are clinics in town, as well as family practice doctors can be certified in that as well.
Okay, I'm putting the evaluation link back up again. And the code is subuse 2.
I'm happy to answer any other questions. I know my email, I believe, is on the final slide, so if people want to send me questions or asking for other resources via email, I'm happy to reply to that.
Linda, I have a question. Just have other communities contacted Empower to, try and recreate this program in other locations?
That's a wonderful question. If I had another hour, I'd tell you all about it. But yeah, we actually had the privilege of serving on the advisory council to the Attorney General's task force for neonatal abstinence syndrome. So I was able to share some of our resources at the state level. And I have assisted communities both north and south of here. Actually, the Empower program started here at Bay State Franklin and Bay State Medical Center in Springfield. We collaborated with them, and they are now share the program there. And again, the materials, I'm always very happy to share them for these moms, to improve the care for these moms. So 2 hospitals, one north in Brattleboro and one in Northampton, Massachusetts, have shared our pregnancy plan and have developed it for their needs.
Great. All right. Well, I don't see any other questions, and it is 2 o'clock. So again, thank you all for joining us. And as I said, you will be receiving a link with all of the materials we showed today. And Linda, I just want to thank you again. This really was such a great combination of professional information as well as personal experience.
Well, thank you. It was a privilege to be here and participate.
All right. Thank you, everyone. Goodbye.